Our next speaker, Dr. Anne Vincent-Salomon, is Chief of the Diagnostic and Theranostic Medicine Division and the Department of Pathology, a professor at the Paris Sciences and Letters, or PSL University, and the director of the Women's Cancer Institute at Institut Curie in Paris, France. Please join me in welcoming Dr. Vincent-Salomon.
Hello, everyone. Thank you, Rachel, for this very nice introduction. For once in my life, I'm going to talk a little bit about prostate cancer. So here are my declaration of interests. The outline of my talk, I will briefly summarize the digital pathology setup at Institut Curie, our experience with diagnostics, AI-guided diagnostics in prostate pathology, and I have a special thanks to my uropathology colleagues, Professor Yves Allory and Dr. Jacqueline Fontune, for sharing their slides. And then I will briefly share with you my experience with quantification of markers in HER2, KCC7, ER, and PR, and the real-life evaluation of the use of Ibex Breast for biopsies, and conclude. So we are fully digitalized, and we were the first one in France with 2 units in 2 different locations to be fully digitalized. So we produced 1,600 slides per day. We are 20 pathologists. So we have pictures of the gross sampling. We have 4 Leica GT450 scanners, 1 Hamamatsu, a nanozoomer, and 2 PAT-scan Epsilon. We have Sectra to look at our digital slides. We have the Daedalus for our laboratory management system, and we secured the storage in our health data warehouse. So this is how we implemented the AI tools. Ibex Prostate and Breast are in the cloud. And we also have Prima from a French startup, but it has been deployed on premises. So what about prostate? We have only 400 prostate biopsy per year at the Institut Curie. So I was very impressed by your numbers, but it represents 30 slides to examine per patient. So the slides are not, the Ibex tool is not fully embedded in our Sectra tool. So the slides are sent from Sectra to the Ibex cloud. They are analyzed, and then we are aware that the analysis is done in the Sectra tool. So we have to click on the image and go to the Ibex viewer. We have been working with the Ibex support team and Emmanuel Steb precisely, with meeting twice a month to customize the solution and adapt it to our practice. And this is very important and very pleasant. So I'm going to go quickly, but this is how it looks like, with the red flag for the cancer and the yellow flag for intermediate cases. So the Ibex tool measures the length of the biopsy. It measures the length and it detects the cancer. It assesses the Gleason score and the perineural invasion. And our results are almost the same as yours, with lower number, but we were very impressed by the AUC. That was about 0.992 for the cancer diagnosis. For the Gleason score, it's also excellent. And for perineural invasion, it's also excellent. We have a good performance for the proportion of uncertain cases. And Emmanuel Steb told us that at the beginning it was higher, and it decreased with all the adaptation we did, and we are around 10 to 11%. So it's a quite a good result. So now moving to breast, I would like to emphasize and to insist that the most challenging part of developing an AI algorithm is the clinical validation. What I mean by clinical validation is that the algorithm is robust enough, whatever the staining, the scanner, and the institution where the slides have been prepared. And really, I would like to acknowledge and say that this Ibex Breast algorithm has been trained like a resident by Judith Sandbank and the whole Ibex team. So I was lucky enough to be able to validate the tool in 2022, but all the AUC from other teams remain absolutely excellent. It means that the algorithm is very well trained and robust. So we have been aware that, and we saw that, the Ibex tool identifies cancer missed by pathologists, very small areas of cancer, but the pathologist was probably tired or distracted by a phone call, whatever. Ibex tool detected it. Equally, it detected ADH or low-grade DCIS missed by a pathologist. So this really matters a lot. What about HER2 quantification? Again, to insist on the fact that there is no active selection by the pathologists of the invasive areas. So it's a fully automated pipeline with automatic detection of infiltrating cells, and the scoring is calibrated according to the USCAP guidelines. So finally, at the single cell level, each cell has a score. So we participated in several studies. This one was aimed to test the potential of AI as a decision support tool for HER2 scoring in breast cancer with the Ibex Breast tools. The manuscript is in preparation by Joanna Sirta from my team. So we studied 2,300 patients coming from 13 different academic or private laboratories in the US, in Europe, and UK, different scanners, different stainings, 43 ground truthers, and 28 readers. So readers had to interpret the slides without any AI, and then after a washout period, they reread the slides with the Ibex tool. Then the performances were compared to the ground truths. And as you can see here, the inter-reader agreement increased really with the use of AI, and that's statistically significant. The accuracy increased also with the use of AI, and so it's really important to be sure that the scores provided by the pathologists are the good ones, and so it increased statistically with the use of the tool, the Ibex tool. This is an example on a surgical specimen, her HER2 low, the ones that we don't like really to interpret because the stainings are not so pretty. However, it has been scored at the cell level, and then the AI slide level score was 40.49%, faint, complete stained cells, AHC score 1+. We did another study. If you were in the room at the platform breast presentation, you just heard me talking about the increased consistency, significant and significantly higher, assisted by AI. So for K67, it makes a huge difference, as you can see, comparing K67 read without AI compared to K67 read with the AI tool. So we had the opportunity to study the real-life evaluation of the use of Ibex Breast for biopsy in my department, and unfortunately, it's not completely embedded in the Sectra platform. However, I was again really impressed by the performances of the AI Ibex Breast tool in our daily practice with an AUC of 0.961 for invasive carcinoma. And if you want to know more about it, please attend our poster presented by Dr. Juliette Sauge, Wednesday afternoon, poster number 15. So in conclusion, I'm absolutely convinced that the quality of the algorithms of each Ibex tools is outstanding. And as I have the chance to be able to compare with other tools, I really mean it. Ibex Prostate is now used by the Institut Curie staff who couldn't work without it now. They are really addicted to it, exactly as we've heard before. So for Ibex Breast, my point of view as head of a department is that it helps to secure diagnosis by double reading. When you imagine the consequences of a diagnosis of breast cancer for a patient, it's better to have double reading, but we can't afford it with a human being. So pathologist plus Ibex tool is really a nice solution. And it increased the inter-observer reproducibility for biomarkers evaluation. And the breast pathologist's point of view is that AI tools must be easy to use co-pilots to help them to do repetitive tasks. So axillary lymph node analysis, and we are very happy to know that we will have soon the Ibex tool for axillary lymph node analysis, or to look for microcalcification. Sometimes it can be boring or time-consuming, and Ibex tool does it very quickly and efficiently. However, you know that I come from France, and we really have serious economic issues. And so for me, my major problem is to find out how to afford AI tools. However, I'm so motivated, and my staff is so motivated that I'm doing everything I can to find out the money to afford it. So now I would like really to thank my beautiful team. Arnaud Gauthier, he's a pathologist, a young pathologist, a kick, I would say. He helped me to set up the whole digital workflow. Jacqueline Fontuni and Professor Yves Allory, who are the uropathologists, and all the IT department, all the technicians, everyone was involved and enthusiastic with it. So thank you also to Emmanuel, and a big hug to Manuela, a virtual one, to Manuela Vesclair. Thank you.